Unfortunately, I wasn't able to join in person, but I will be looking forward to participating on site in the upcoming events. And I believe the conference must be running smoothly, successfully, and all of the participants are enjoying the conference. So today, I will be discussing about atrial fibrillation guideline and current practices, mainly referring to Mongolia condition. So in terms of atrial fibrillation, we know that this is a prevalent condition with difficult impacts and outcomes at patient level, causing a lot of difficult symptoms, starting from palpitation to anxiety and depression, and poor exercise capacity, causing decrease of their normal living, and it will have different adverse outcomes, including recurrent hospitalizations, heart failures, and ischemic stroke that I will be discussing mainly today. And not only at the individual and family level, but it's also costing at healthcare and society or community level. So the current guideline is recommending that whenever there is an atrial fibrillation patient, we should provide them with patient-centered integrated care being management of comorbidity and risk factor, avoiding stroke and thromboembolisms, reducing the symptoms by means of rate and rhythm control, and then evaluation and reassessment of the patient to give them better and patient-centered management. So whenever I discuss about this issue, I like to refer to a registry study where they took stroke prevention, symptom control, and comorbidities, how it is actually affecting all this management tools, affecting the patient's survival. So considering the stroke prevention, symptom control, and comorbidity being one each criteria, when we look at the Kaplan-Meier, if you have one or two or all of the criteria or all of the management well adhered, it's always better than non-adherence to any of the treatment options. And actually, by providing this care, you could dramatically reduce all-cause death and major adverse cardiac events. So, of course, among these treatment criteria, the avoidance of stroke and comorbidity disease management were more significantly reducing the risks among the patients compared to all the symptom controls. But then if you could manage two of them, it was of course better than only one criteria being accomplished. Or of course, it's always better if you could fully adhere the patient to all of the treatment options. And then the same group also did the systematic review and meta-analysis, and they could find from more than 280,000 AF population, only 20% were adhered to all the possible treatments. But each time we have to think if we could manage our patients properly, we could reduce their all-cause deaths, reduce their cardiovascular death, ischemic stroke, and major bleeds. All will be reduced significantly. And these numbers are not low, these numbers are high. If we could provide them with good care, we could prevent them from a lot of problems or complications, outcomes. Until now, Mongolia did not have any national registries or nor prevalence studies, but the National Cardiovascular Center, we are trying to initiate a national registry on atrial fibrillation, and after development of the questionnaire and study plans, we did some preliminary study just to analyze how is the situation. And here we find the male population among AF patients actually having worse compared to the female population, worse condition in terms of comorbidity and risk factors. They had more obesity, they had more uncontrolled hypertension and heart failure, ischemic heart disease. So we have to pay attention to this. But importantly to my talk, we analyzed the charts-wide risk analysis among all the atrial fibrillation registrants, and then we identified that most of them had moderate to high risk or low risk patients, being around 30%, moderate risk being 64%, and high risk being 6%. So these patients needed to take anticoagulation therapies, but when we look at the medication adherence of these patients, nearly 80% were off medication. They were not taking medication, or they been not prescribed proper medication. So only 21% had proper anticoagulant therapy ongoing during their visit to our clinic. And these are the patients from all over Mongolia referred to our center. So when we look at the medications prescribed, there were oral anticoagulants and warfarin, but among those who've been prescribed with warfarin, majority of them, or more than 90% of them, stopped their medication. And this was mainly due to, especially in the periphery, due to unavailability of the INR testing. So these patients could not follow up their anticoagulant status. So this was not preferred by the patient and not preferred by the physicians in their provinces or in their regions. Although oral anticoagulants majority still continue, not majority, but 40% still continue their medication, but quite significant amount of them also stopped the medication, mainly due to the price of the medication on one side and also availability of the medication, because only rivaroxaban is available on the market, but time to time there is a shortage of medication. So looking at this statistics, I think we think that first we need to find some alternative medications for rivaroxaban, or make our availability of the medication better. In terms of warfarin usage, we need to find a good way to analyze INR, especially in the periphery, and even in the central capital city. We need to have good flow good flow of these patients to be testing their INR as needed, and to have good flow for these patients. So these things we need to consider in order to improve the medication adherence to be better. And is this non-adherence to medication among stroke patients, among atrial fibrillation patients or high-risk patients affecting the outcomes? We have this study from our neurology team. They analyzed over 500 patients for their stroke, and 33% of them had ischemic stroke. Among them, 35% had cardioembolic genesis. And of course, majority of these strokes, nearly 90% of them had atrial fibrillation as cause of their cardioembolic ischemic stroke. Then they analyzed that paroxysmal atrial fibrillation is actually causing even higher risk for those patients to have stroke. So, and then when you look at the anticoagulant use before their stroke condition, actually should not say interestingly, but many of these patients still received antiplatelet therapy before the stroke. So this is expressing not only the patients, but we need to have properly educate our professionals, especially those at the primary care, because in Mongolia, especially those who are living in the periphery, in urban areas, peripheral areas, in the countryside areas, atrial fibrillation patients are taken care by the primary care physicians. And so from here, we are still finding a lot of patients prescribed antiplatelet, especially poor antiplatelet therapy, even if the guideline is recommending anticoagulant should be used. And then again, many of the patients already stopped anticoagulants, and then also a significant number of them had no medication. So anticoagulant use really need to be improved in our condition, and this needs a major major change in the medical practice. We need to educate our professionals, especially who are facing atrial fibrillation patients at the periphery, and then we need to educate or make our patients as center of the management to cooperate with them very well, so that they would not stop their medication at any time, and that they would continue with their anticoagulant medication. Meantime, we need to, how to say, properly think about the workflow of follow-up of these patients, especially those who are taking warfarin, to have easier access to INR testing. And from here, we also consider that maybe early identification is also one of the causes that we are not prescribing anticoagulants, or these patients are being non-medicated. And then when we think about our medical practice in Mongolia, major hospitals, many hospitals are doing Holter monitors just to identify if these patients having atrial fibrillation or not. So most of the Holter tests are done continued within 48 hours, 24 to 48 hours. So at our Holter Analysis Center, we analyze all these measurements, over 300 measurements of up to 48 hours and over 170 measurements of over 120 hours or 5 to 7 days of Holter. And then when you look at we looked at the initial episode of occurrence of atrial fibrillation, and of course, if you had long persistent or permanent atrial fibrillation, you immediately had the diagnosis. But if you had paroxysmal atrial fibrillation, within 48 hours, there was almost no occurrence, and initial episodes occurred starting from the third day to fourth day and then above. So we are testing our high-risk patients with Holter monitors, but we are not being able properly to identify these patients. So we need better early screening programs to identify these patients in need to start their medication. So atrial fibrillation is still a highly prevalent condition in our population, possibly with low screening and low identification. We do need to identify them as early as possible to prescribe them with the proper medication, and we need to improve the care adherence among our patients. So thank you with that, and I hope you would enjoy the rest of the conference. Thank you very much.